Hi, everyone. I was just reminded that I had not finished just the very end of postoperative care, and so I apologize, but here it is. We talked about elevations in temperature, and we're going to move forward with that, understanding how we manage that. Typically, we see elevations in temperature postoperatively categorized as mild, moderate, or quite severe. So mild elevation up to about 38 degrees. We see that in the first 48 hours. That can result from a lot of things, and really quite significantly just a stress response. So we're always looking for above 38 or 38.5 as the real marker for fever. Usually what we're going to see within the very first period of time is a respiratory congestion or anaphylactosis. Sometimes we see an elevation in temperature from dehydration, and that's why we really want to watch fluid status postoperatively. And when we're looking after 48 hours, a moderate temperature, not even a very high one, 37.7, or even a marked elevation usually indicates some type of infection. And in class, we talked about that whole, wound, wind, blah, blah, blah. So we talked about all of that in class to look at sort of the frequency and the causes of that elevation of temperature. So let's think about this. Temperature elevation gives us a lot of information about what's going on with our client, what is distressing both to their body and the cause of that. So we can have infection appearing in the site of the surgery, so surgical site, a wound infection, respiratory tract infection, and that's often related to the fact that a patient was intubated and ventilated. So when we intubate a person and we put them on a ventilator and we give them that anesthetic, the cilia in our lungs, the ability of our lungs to actually move those small little particulate matter up and out is decreased. So the same way that our GI system sort of goes to sleep when we are involved in GI surgery, those cilia, they are not effective. And so we are not able to clear, just at a cellular level, not able to clear secretions as well from our lungs. Additionally, patients post-op typically will have, unless I have surgery on my hand, typically are going to have some difficulty with that deep breathing and coughing if I've had any surgery, thoracic or GI kinds of surgery, because of the pain it causes. Even if I have some peripheral surgery, let's say I have a major surgery on my leg, deep breathing and coughing can lead to pain just because it tends to move our bodies. And so that positional change can cause pain. So that decrease in our ability to clear those secretions, which may also be thicker because of our fluid status. Often we see urinary tract infections, and most commonly, unfortunately, related to catheterization. So we see that HAUTI, hospital-acquired UTI, which is really unfortunate, and that's why we've moved as much as possible not to catheterizing. But for an OR patient who undergoes anesthetic is certain to become incontinent of urine, and that's going to lead to other risk for infection in an OR setting and lack of safety when we have a wet setting. So it's really important that a patient is catheterized and that we keep that catheter in for as little time period as possible. Sometimes it can be from thrombophlebitis at an IV site, and we're going to watch that particularly a week or so after surgery. We can see this hospital-associated diarrhea called C. difficile or Clostridium difficile, and often that stool has a very characteristic smell and is quite slimy. You would see it as quite slimy. And also a patient can become septic. Septicemia is one of the most significant complications postoperatively. So remember, we're back on a clinical unit, and how are we going to manage a patient when we see this beginning elevation in temperature? For sure, we're going to be looking at airway clearance. So deep breathing and coughing. Sometimes we see patients still using an incentive spirometer. There's good evidence that they're effective, that incentive spirometer that causes a patient to breathe in, hold the ball up, and then let it go down slowly. It's not that you need to do it quickly. In fact, we do it in a slow, regular way. But that really encourages that good airway clearance. The challenge is that those are single use and very effective, those incentive spirometers. So we see it less and less. We know technique for deep breathing and coughing. You've learned it in the program. We also talked in class about splinting. So when it's difficult to use a pillow to splint if there's some discomfort, and also if patients are really struggling with deep breathing and coughing, to move to like huffing, not huffing where we're inhaling solvents, but actually huffing to just, instead of a full cough, just to do, I'm going to see if you can hear the sound like a, and that starts to move those secretions. If we see a fever and if we think that there is any infection possible, we want to make sure we take a chest x-ray, we get an order for a chest x-ray, and also some sputum cultures so that we can see if the site of that infection is lungs. Once a fever gets to a significant level, so 39.5 in particular, we want to make sure that we use some antipyretics, so some Tylenol or some ibuprofen, something like that, to bring that fever down for comfort. We're going to do vital signs more frequently, so at least every 4 hours to see what's going on with that temperature. We're going to look at all the possible sites. So we're going to look at urine, we're going to observe a wound, we're going to take swabs if we think that that's appropriate. We're going to look at IV sites and make sure those are clean. Again, we talked about chest x-rays. Let's talk about GI problems post-op. Depending on the kind of surgery we've had in particular, many patients experience nausea and vomiting post-op. Now, abdominal surgery is the most significant in terms of those experiences. One of the things about abdominal surgery is that our bowels do not like to be touched. So as soon as we are involved in any kind of surgery that touches those our bowels, they go to sleep. They stop moving. And remember, we have constant peristalsis through our bowels. And so that stops. And so typically now our body does not like the feeling of that peristalsis either slowing down significantly or stopping briefly. And the results are often nausea. It can be vomiting. Even more significant, if we get to the point where they're not just slowed down, but they're stopped, we can have what's called a paralytic ileus, where nothing is moving through. And that can lead to vomiting and significant distress. Anesthetic and also medications that we can give a patient for associated with their surgery. So pain medications may cause nausea and vomiting. Anesthetic for sure, nausea and vomiting. Pain can cause nausea and vomiting and other things. So it's very common and quite a significant experience for patients post-operatively. Predisposed patients to nausea and vomiting post-op include younger patients, interestingly enough, under 50. Female patients are more likely to experience it. Patients who experience motion sickness are also more likely to have nausea and vomiting post-operative. So that's just someone who has some sensitivity potentially in their hypothalamus that leads them to experience nausea much more readily. Another interesting thing is that non-smokers are more likely to experience post-operative nausea and vomiting. We're carrying on with GI problems. So when do we think a patient can resume fluids? So for patients who've had other kinds of surgeries, let's say I've had orthopedic surgery or a C-section, something like that, as soon as the patient has a gag reflex, if they have had general surgery and they've been intubated, there may be an issue with their gag reflex. We want to make sure a patient has a solid gag, and we would allow them to begin introduction of fluid. Again, we're going to check our orders to make sure, but that's what we would anticipate. Difference is for patients who've had bowel surgery, right? Any kind of patient who's had some kind of abdominal surgery, they're going to remain NPO post-operatively. Typically, we're going to give IV fluid, and for a patient who is NPO, we would want a hydrating fluid, something like normal saline. Immediately post-op, we might see Ringer's lactate. We might see a patient on 2/3 and 1/3, which has a little bit of glucose, just enough for cellular metabolism typically, and also so that they're getting enough fluid from the intravenous, and also an NG tube for decompression, so that the NG tube will, if it's to suction, will remove stomach contents, so that acid that your stomach continues to make, and also so that you don't have that air in your stomach, and for comfort of the patient. We're going to slowly move the patient up from being NPO to clear fluids. And here, let's talk about that. We advance a diet typically as tolerated. So often you see that DAT, diet as tolerated, and it's a slow process. Moving too quickly from NPO to clear fluids to sometimes you go right to solids, or sometimes you go to full fluids. It depends again on the entire process that a patient has experienced. Moving too quickly can lead to vomiting and more significant complications. And a patient who's having a lot of pain, has incisional discomfort, that's going to make that even worse. So clear liquids are exactly what we described. You can see through them. So it could be juices, it could be clear tea, or sometimes black coffee, but more often a patient can tolerate a little bit of clear tea more effectively. It can be broths. Clear liquids can also include Jello, but you don't want to get to like solid Jello until you've had actual liquids first, and just start with sips. The very first clear liquid they're going to have is a little bit of water, right? You might even start with ice chips first. Depending on the situation, if a person has an NG tube and their MPO, and again, you're going to be very cautious with this, and you're going to make sure that there is an order available to you. Sometimes as a measure of comfort, a patient can have, even with an NG tube, can have a little bit of ice chips, knowing that the NG tube is going to still suck that out. We wouldn't do that without getting an order or clarifying that with the doctor, but that can be for real comfort, because your mouth feels terrible when you are MPO. So we want to make sure that we give regular mouth care, help a person to brush their mouth and brush their teeth, and rinse with, if they like to have some diluted mouthwash, if they don't, it's up to them, but regular mouth care really helps them to feel better, because their mouth and their tongue can feel horrible. We also want to make sure that we give a patient, administer antiemetics if they are nauseated, and typically we would see just what you might take at home, Gravol. We can give that IM or IV. And if a patient has moved to a full diet, we might be able to give Gravol even PO if the patient is just nauseated, not vomiting. If that persists, that nausea or vomiting persists, it may be that a patient requires an NG tube to be put in so that we can drain the contents of their stomach, and that may alleviate some of that distress. So important post-op that we get a patient up. So early and frequent ambulation cannot be stressed enough. That's going to help prevent abdominal distension. It's going to help us to move gas. For patients, it's a real victory post-operatively when you've had GI surgery in particular, to be able to pass that gas. Sometimes we can even help a patient to do that by inserting a rectal tube, just so that they don't have to push that gas past their rectal sphincter. But early ambulation is important, and that will help to return to normal peristalsis, so that movement of that GI system. It's so important that we help patients to understand that expelling flatus is a victory. It is not something to be embarrassed about. In the hospital, we all celebrate when a patient passes some gas. We help them to do that by getting up and walking around, changing their position. And again, sometimes, and again, particularly GI surgery, you may use a rectal tube. It doesn't make it's not that it's magical, but it can help because they don't have to push. And if you've had abdominal surgery, that intra-abdominal pressure that you create by trying to push your gas past that rectal sphincter can be painful. What else are we looking at? Low urinary output. Now, it's interesting. If you do a fluid balance for a patient in the OR, you may see that they've actually had a lot of fluid. It looks like they are maybe 2 or 3 or 4, or on big surgeries, 10 liters up. So they've had a lot of fluid. And then you're wondering, why is it that they're not making so much urine? In PACU in particular, we may see a sub-therapeutic level of urine, just sub, not profoundly low, within the first 6 to 8 hours post-operatively. And that's because stress of surgery has led to that increase in aldosterone and ADH, that fluid restriction or fluid losses during surgery can have an impact on that, although again, we have typically done a good job in estimating fluid losses and providing intravenous replacement. Sometimes we have drainage or diaphoresis or other things, but most often we have third spaced, in particular because of intubation and anesthetic, we third space our fluid. So we have enough fluid in our body, but often it's not available to us. So we've moved it into third spaces, and we have to bring it back into circulating volume. Your body does that as a natural process, but it needs a little bit of time. There's a little bit of lag time before your body can start recovering. It's sort of like in, it's sort of in a startled phase. I don't want to say shock because you'll think I'm talking about physiological shock, but it's in a startled phase. And in that phase, your body wants to hold on to its fluid, because when we think of stress, what you don't do, you want to hold on to all your resources. And that's fluid is one of them. So we expect in PACU, we may see a slightly lower than therapeutic amount of urine. That shouldn't continue, and often a patient will diurese after that period. When we think about complications within 30 days after surgery or within 1 year of implant surgery, it's really important that we look at the potential problems associated with that, right? So when we look at skin or integument issues, we want to watch for purulent discharge and looking at what kind of organism is causing that infection. Most often it's staph, and we need to be aggressive in treating that. We can either have a diagnosis by a physician based on the culture, or we can have radiological diagnosis when we have, let's say, hip replacement or something like that, where it's not physically obvious on the outside of a person, but we may see something like an osteomyelitis or something else that is occurring within the implant. We all know this from other courses, but when we're looking at what the signs and symptoms of that are, wound infection or skin infection, we see redness, we may see swelling. Often a person experiences pain and tenderness at the site, and sometimes you see that pain and tenderness even before we see that redness and swelling, but they're all sort of a cascade of effects. So thinking about surgical wounds, what we want to do is make sure that we have monitor our patient pristinely. If we see excessive or abnormal drainage, so I see a purulent drainage, I see more drainage than I would expect from a site or from a tube or a drain, then I want to make sure that the surgeon is aware, because it is the surgeon's responsibility to assess for that, and we need to respond rapidly so that a patient does not become septic from that wound infection. We also are watching for changes in vitals, although remember, vitals are a late sign, not an early sign. So we're going to watch for slight signs, or those early signs first: increase in pain, difficulty moving, maybe some redness, some swelling, some warmth, things like that. And also watching to see if we have an increase in temp, an associated increase in heart rate that happens with that. A change in blood pressure is a very late sign. So that is a very late sign when we see a drop in blood pressure and we're moving to sepsis there. Important to consider the number and type of drains, whether we have a Jackson Pratt or a Penrose or other kinds of drains when we're changing the dressing. Looking at the incision site, examining it, and describing it, making sure that we have adequate light so that we can see what we see. If we see, and again, you're going to look at agency protocol and policy, but if we see purulent drainage and there has yet to be a swab taken, I have never been in a situation where the expectation was not that you would take that swab without an order, because we don't want to delay that and wait, let's say, till the doctor's on the unit 12 hours later. Because instead, what I could do is send that swab to the lab, and by the time the doctor is there, if the patient is stable and there's nothing I need to do to contact the doctor about in the meantime, I may have some preliminary results. Important that we always are using clean gloves with our dressing changes, and that we employ sterile technique. And you learned that pristinely, I know, in your lab, and I know you are all excellent in terms of your skills. Psychological function is really important to consider. Absolutely, surgery is stressful, and all of us may experience anxiety or worry, but the consequences of change in sensory input, the use of anesthetics, the use of other kinds of medications, pre-op and post-op medications, and pain medications may result in a lot of psychological consequences as well. Confusion is a really important one, and delirium. So it's important to differentiate dementia from delirium. I know you did that in year one. But in particular, when you've got patients who are older, we want to make sure that the changes in sensation, the changes in environment, and the combination with medications and a traumatic experience of surgery may lead to that experience of delirium, and we would watch for that and intervene appropriately. Additionally, things like fluid and electrolyte imbalance that are very common, commonly associated with surgery. Hypoxemia, so a lack of oxygen at the cellular level. The effect of drugs, and I talked about that. Oh, sleep deprivation is a terrible one. When we think of how much our sleep cycle is impacted by sleeping in a different bed. I don't know if any of you have been in a hospital bed, although it's nice to be able to move up and down the head. It's really not comfortable at all. You may be in a room with other people. You are often in pain. You're not able to get up as easily as you might be at home to go to the bathroom and other things. Sleep deprivation, there's a lot of noise, including all of us at the nursing station and other places, right? So sleep deprivation is really difficult and can lead to that confusion, and for older people in particular, delirium. And also all of that sensory overload can be very distressing. For patients who have a history of alcohol use, in particular alcohol addiction, so chronic alcohol use, we can see alcohol withdrawal, and that can present as delirium tremors or DTs. We call that because we often see those fine tremors in the hands. If we suspect that there is any possibility that a person is undergoing some alcohol withdrawal, we want to ask the patient just the way we would ask any other question. If they have a history of alcohol use and other things, we ask it in a non-confrontational, non-judgmental way, because our goal is to help that person. And we would want to make sure that we intervene early to prevent the escalation of those symptoms, and we would medicate that patient. Post-anesthesia and ambulatory surgery discharge criteria are really helpful to know. So post-anesthesia, we want to make sure that the patient is awake, right, or whatever condition they were in when they arrived. Their vital signs need to be stable, and we look at not only the norms, but their previous pattern. We see no excessive bleeding or drainage. That respiratory status is within normal limits, so no respiratory depression. Remember, they've been likely intubated or put under conscious sedation. So we want to make sure they're breathing well. Their O2 sat is above 90, and that we hand over a report. When we're talking about ambulatory surgery, we need to make sure that all of the discharge criteria from the PACU are met, that they haven't had IV opioids in the last 30 minutes. We don't want to give somebody a dose of IV opioid and then send them out the front door, because we don't know how they're going to respond. We don't know if they're going to, as they start to get up. So giving somebody an IV opioid while they're lying down is quite different than giving somebody an IV opioid and letting them get up and walk away. Their blood pressure can drop. They can be very confused. A lot of, often you'll have fainting and other things. So we want to make sure that there has been a significant period of time, minimally 30 minutes before we let somebody go. Minimal nausea and vomiting. We're not going to send somebody out the door with a K-basin in their hand, although sometimes I'm so sorry you do see that. Minimal nausea and vomiting is an important criteria for discharge with ambulatory surgery. We want to make sure that they have voided, so they've been able to void. One of the complications post-op is that anesthesia can actually impact our ability to void. And so if a patient hasn't voided, the classic criteria is if a patient hasn't voided within 8 hours post-op, that patient needs to be catheterized. That we would get an order for that, and that would be an in and out catheter typically rather than leave it in. But all patients who are to be discharged from ambulatory surgery should be able to void before they go. Again, if it's age appropriate, if it's not contraindicated, depending on the kind of surgery, we want to make sure they can ambulate. They cannot go home alone. There needs to be a responsible adult present to accompany the patient, and written discharge instructions need to be given and understood. So we can't just give them verbal instructions, but written instructions need to be given to send the patient home. So when you're on a clinical unit, you'll receive report from the PACU nurse. The PACU nurse will talk about not just their period of time in the PACU, but their operative procedure, what happened in the OR, how the patient tolerated, often talking about fluid balances and other things. The PACU nurse then will cover post-operative care, what happened in the PACU, how the patient is tolerating all of their prescribed, let's say, treatments, fluid, medications, other kinds of things. They'll talk about pain, and we really want to keep an eye on that. And you as the receiving nurse, you're going to assist with transferring that patient to the bed, making the patient comfortable, making sure you understand all of the report that you've received. If you have any questions, it's important that you ask them then. If you find that you have questions that didn't occur to you at that point, it's fine to call the PACU nurse, but typically that PACU nurse has moved on and is looking after other clients. So important that at the time you're getting a report, anything that comes to mind, ask it and make sure you're very clear and that you've got all of the chart materials there with you. When we receive a patient to the unit, we want to do vital signs right away. And we want to compare those to what we were given in report and what has been charted and look at a pattern. We want to do a full head to toe. Often when we look after our patients, we're not doing full head to toes, we're doing focused assessments, except at the beginning of our shift, then we move to focused assessments. Receiving a patient from PACU, it's really critical that you do, again, that pristine head to toe assessment. Then we're going to look at post-op orders. And you remember in class, I told you that all pre-op orders are nullified when a patient goes to the OR. So everything needs to be reordered after the OR. Medications often change, treatments often change, things like that. So everything needs to be reordered once the patient has undergone surgery, and you need to initiate all of those orders post-op. It's important, again, depending on the kind of surgery, the status of the client and other things, to see if we can get that patient up at an appropriate time. It's important for their GI system that we talked about. It's going to help with their urinary function. It's going to stimulate circulation. And one of our post-op risks is that we're going to develop a DVT or a pulmonary embolus. And so we want to get our blood circulating. Getting a patient up to ambulate is going to help with respiratory function as well. And it's also going to help with urinary function. Remember, we talked about anesthetic and your urinary system as well. So all of those things are important. If a patient has any kind of physiological challenges with mobility, it may be that we want to have physiotherapy up for that first ambulation, or we want to use ambulation aids, a walker. Sometimes for patients who've had major surgery, a high walker, which gives them a lot more support, not just that low walker, but where they're putting their arms up at almost at shoulder level or mid-chest level to provide some support. If we're getting a patient up for the first time, we may want 2 nurses present, things like that. So we're always problem solving and being vigilant about what might happen as opposed to just reacting to what is happening in front of us. It's really important that when we're discharging a patient, again, from ambulatory surgery or even inpatient surgery, sometimes depending on how long they have been in, the client may not drive themselves. So they have to be driven home by somebody else. They cannot just take an Uber home or a taxi home. A responsible adult must be there for the discharge instructions and to take them home. And typically what you're going to see is that there's a follow-up phone call to that patient to check in and see how they're doing, and to follow up to see if there are any further questions or there's anything going on that we need to work through with the patient. It's important that as soon as the client arrives from the OR, we begin that process of discharge planning when it's for an inpatient. Even from the period that a patient is sort of admitted preoperatively or surgery is scheduled, begin the process of determining what resources are going to be needed and how we are going to help a patient return back to their preoperative condition, whether they live at home, whether they live independently or in a nursing home or long-term care facility, assisted living, however that's going to begin. It's important that we have planning in place to see what kind of assistive equipment they may need, or what that post-op period is going to look like in terms of support that they may need and other things. When we're discharging a client from a clinical unit, it's really important that we provide information that is going to help them to make decisions on a day-to-day basis about the kinds of things that we take for granted. So things like care of the wound and dressings, and are you allowed to bathe or shower? Can you just do a sponge bath until you come back to see the doctor? All those kinds of things. Patients often go home and one of the most common questions they have is, oh, I forgot to ask, am I allowed to take a shower? We want to talk to them about any medications that are new medications, how that medication works, what are negative effects of that medication, when to take that medication, what to avoid, other kinds of things. You can do that medication counseling. Sometimes the pharmacist is an excellent member of the interprofessional team to do that counseling with you. We want to talk to them about what they're allowed to do and what they're not allowed to do. So for example, if you have orthopedic surgery where it's a joint replacement, hip surgery, knee surgery, we talk about driving. For some of you who had patients with C-sections, in the fall term, patients with a C-section aren't allowed to drive for a period of time. So we talked to them about the activities that are allowed and the activities that are not allowed, and the time frame, and when and how they would be cleared to return to that activity. We're going to talk to them about their diet, if there's anything that they can't eat or drink, if they need to modify anything, and what to watch for. We want to talk to them in general about what kinds of things to look for, and what they do if they see those kinds of things. Are they following up with their family doctor? Are they following up with the surgeon? Is there a discharge planner who's going to keep in touch with them following discharge? We provide them with instructions for follow-up care when they come back to a clinic or back to the doctor's office, or how they follow through with that process. We make sure that if there are any questions or concerns, we leave lots of time and space to answer those. We're not standing at the bedside trying to race them out with a wheelchair in our hands. We want to make sure that we have documented well in the chart all of the discharge instructions that we gave. We want typically to give written discharge instructions to the patient and their the other adult who's there with them, the responsible adult, so that when somebody goes home, they have something to look at. I often forget if you give me 10 things that I need to follow up on. So it's really helpful to have written instructions, and it's necessary. And often we see a follow-up call or a visit to just see how the client is doing after discharge. We really want to make them aware of what is most important that they can do, that they can't do, and that they should watch for. And in those situations, how they should respond. So do they call someone? Do they return? All of those kinds of things. And that's the end of that. And I'm sorry to stop talking about post-op care, because my background before I was an emergency nurse was working in surgery. And it is, if I think of the loves of my career, nothing is as good as the emergency department, but certainly surgery is without doubt very, very close to my heart. All right, and that is the end of this lecture. And I will talk to you again soon.